You're about to be put under anesthesia. Perhaps tomorrow, perhaps next week. And right now, you're frightened. You want to understand what's truly going to happen to you. Not the polished version they present during the preoperative briefing. The reality. What actually takes place in your brain, your body, your awareness when they put you under. And I'm going to lay it all out for you, because you have every right to know. My name is Dr. Dan Carter, and throughout my career, I've witnessed this process thousands of times. I've watched people slip out of consciousness in seconds and return hours later with no recollection of anything in between. I've seen everything go flawlessly, and I've seen things go sideways. What I'm about to share is what genuinely occurs in that operating room. The science, the dangers, the things the medical team doesn't always disclose because they'd rather not frighten you. But you're here because you want the unvarnished truth. So let's get into it. First, let's tackle the question everyone has but is afraid to voice. Will I wake up during surgery? It's known as anesthesia awareness, and yes, it does occur. But before panic sets in, let me give you the actual figures. It happens in roughly 1 to 2 cases out of every 1,000. That's 0.1 to 0.2%. Your lifetime odds of being struck by lightning are actually higher. But it does happen, and when it does, it's deeply traumatic. Patients describe being immobilized yet alert, hearing conversations, feeling sensations, unable to signal that they're conscious. Safeguards exist to prevent this. Monitors that track brain activity, medications calibrated with precision. But medicine isn't flawless, and you should be aware of that. Now, here's what actually takes place when you go under. You're lying on the operating table. The surgical lights are glaring. The room is cold. It's always cold, because lower temperatures inhibit bacterial growth. The anesthesiologist is standing beside you. They've introduced themselves. They've reviewed your chart. They know your medical history, your allergies, your anxieties. And they're about to do something that is simultaneously awe-inspiring and deeply unsettling. They're going to shut off your consciousness. Consider that for a moment. Consciousness, the thing that makes you who you are, the awareness of being alive. They're going to chemically erase it. And then, once the surgeons have finished opening your body and repairing whatever needs repair, they're going to restore it. Like toggling a switch off and back on, except it's not a switch. It's a meticulously orchestrated chemical intervention in your brain. Here's the sequence, step by step. First comes pre-medication, typically something like midazolam, a benzodiazepine. It accomplishes 2 things. It eases your nerves and reduces anxiety. And, this is the part patients find unsettling, it induces anterograde amnesia. You won't retain any memory of what occurs after it's given. You might be chatting with the nurses, cracking jokes, signing additional consent forms, and afterward, you'll recall none of it. Your brain simply stops recording new experiences. Then comes induction. You're instructed to take several deep breaths of pure oxygen. This is called pre-oxygenation, because in about 60 seconds, you're going to stop breathing independently, and the anesthesiologist needs your blood loaded with oxygen to buy precious time while they secure your airway. You breathe the oxygen, and then propofol is pushed into your IV. Propofol is white. It resembles milk. Medical teams sometimes jokingly refer to it as the milk of amnesia. It stings as it enters. Patients frequently say it feels like their arm is on fire. That's normal. It's not causing any harm. It simply triggers pain receptors as it travels through the vein. But you won't be bothered by the sting for long, because within seconds, you're gone. And when I say gone, I mean completely gone. Propofol acts faster than nearly any drug in the medical toolkit. 8 to 10 seconds from injection to loss of consciousness. Your eyes roll upward. Your body goes slack. Your breathing ceases. For all practical purposes, you've entered a state remarkably close to death. Your consciousness has been erased. And now it falls to the anesthesiologist to keep you alive. Here's where things get fascinating. We don't actually understand how anesthesia works. We know what it accomplishes. We can observe its effects on brain imaging. But the mechanism, the precise process by which these chemicals extinguish consciousness, remains a mystery. Theories exist. The dominant one holds that anesthesia disrupts communication between different regions of the brain. The prefrontal cortex, responsible for awareness and decision-making, gets severed from other areas. Your brain stops weaving information together. And without that integration, consciousness ceases. Just fragmented neural activity going nowhere. But back to you on the table. You've stopped breathing. So the anesthesiologist is doing it for you. A mask is placed over your face. The attached bag is manually compressed to force oxygen into your lungs. Your chest rises and falls. Monitors are tracking everything. Oxygen saturation, heart rate, blood pressure. All of these begin shifting the instant you lose consciousness. Now the airway must be secured. You're going to be unconscious for an extended period, and manual ventilation can't be sustained throughout. So the anesthesiologist performs intubation. Your mouth is opened. A laryngoscope, essentially a curved metal blade fitted with a light, is used to visualize the vocal cords. A plastic tube is guided down through your trachea and into the windpipe. This tube connects to a ventilator, a machine that will breathe on your behalf. Intubation is a refined skill. It demands years of practice and doesn't always go smoothly. Some individuals have challenging airways, anatomical features that make it difficult to visualize the vocal cords. When that occurs, there are contingency plans. Video-assisted laryngoscopes, alternative devices. In extreme situations, a surgical airway can be created, but most of the time it proceeds without incident. The tube slides in. A small cuff at the tip is inflated to hold it securely. Correct placement is verified by listening to the lungs. And now you're connected to the ventilator. But you're not merely unconscious, you've also been paralyzed. A neuromuscular blocking agent has been administered, typically rocuronium or succinylcholine. These drugs sever the communication between your nerves and your muscles. Your brain can transmit all the signals it wants. Your muscles won't respond. This serves a dual purpose. It makes intubation easier because the jaw and vocal cords relax completely, and it prevents you from moving during the operation. Even unconscious individuals can exhibit reflexive movements, and that can't happen when a surgeon is working inside you. So now you're unconscious, paralyzed, and breathing through a machine. But the anesthesiologist's work is far from over. Maintaining your unconscious state demands constant, unwavering attention. What's being employed is called a balanced anesthetic, typically a combination of inhaled anesthetic gas, such as sevoflurane, and intravenous medications. These are adjusted continuously based on what's happening surgically and how your body is responding. Your blood pressure drops during surgery. That's expected. Anesthesia causes vasodilation. Your blood vessels relax, blood settles in your extremities, your heart doesn't have to pump as hard, and pressure falls. If it falls too far, vasopressors are given to bring it back up. If your heart rate slows excessively, atropine is administered. If it accelerates too much, beta blockers. The anesthesiologist is perpetually making fine-tuned adjustments to keep your vital signs within a safe range. And here's something most people don't appreciate. They aren't in the operating room multitasking. They aren't glancing at their phone or having casual conversations. Their entire concentration is fixed on you. They're monitoring dozens of variables simultaneously. Oxygen levels, carbon dioxide levels, ventilation pressures, heart rhythm, body temperature, depth of anesthesia. Listening to your lungs, observing your chest rise and fall, checking your pupils, assessing your skin temperature. All of this reveals how you're doing. The surgery proceeds. The surgeon carries out their work. And you are somewhere else entirely. Not sleeping, not dreaming, simply absent. Research has demonstrated that under proper anesthesia, the brain doesn't generate dreams. There isn't sufficient activity. You aren't asleep in the conventional sense. Normal sleep is an active process. Your brain cycles through distinct stages, and dreams emerge during REM sleep. Under anesthesia, none of that occurs. Your brain activity is suppressed, muted. There's nothing to recall because nothing is being experienced. Except when something goes awry. On rare occasions, the anesthesia isn't deep enough. The patient begins to lighten. There are telltale signs: tearing eyes, a climbing heart rate, subtle movement. If the paralytic has partially dissipated, the response is immediate. The anesthetic is deepened. But occasionally, in that brief window, patients can have experiences. They hear things, feel things, and because they can't move or communicate, it's terrifying. This is anesthesia awareness, and it's precisely why brain monitoring technology exists. EEG-based systems that track electrical activity in the brain and indicate how profound the anesthesia truly is. But let's address the moment that frightens people more than any other: waking up. The surgery is wrapping up, the surgeon is closing, and it's time to bring you back. The anesthetic gases are discontinued. The intravenous medications are tapered down. The body is allowed to metabolize whatever is still circulating. The drugs begin to clear. Brain activity starts rising. You're transitioning from that suppressed state back toward awareness. But you're still paralyzed, still intubated. This is a critical juncture. You need to regain enough consciousness to breathe independently, but the breathing tube can't be removed until your protective airway reflexes have returned. If it comes out prematurely, you could aspirate. Stomach contents could enter your lungs. So the anesthesiologist waits, watching for signs of awakening, movement, response to verbal prompts. Squeeze my hand. Open your eyes. Take a deep breath. When those signs appear, when there's confidence that you can safeguard your airway and breathe adequately, the paralytic is reversed. Sugamidex or neostigmine is given. These agents counteract the neuromuscular blockade. Your muscles begin functioning again. You start breathing on your own. The ventilator is still providing support, but your own respiratory effort is evident. And then the tube is withdrawn. The cuff is deflated. The tube is drawn from your trachea. You cough. You gag. This is normal. You may not remember it. That's the lingering amnesia from the medications, but it happens. And in those initial moments after the tube is removed, the anesthesiologist is still watching you intently, confirming you're breathing sufficiently, confirming your oxygen levels remain stable, confirming you're safe. You're conscious now, more or less. You're in what's called emergence, that twilight zone between unconsciousness and full awareness. You may be disoriented, restless. Some patients emerge combatively, thrashing about, a phenomenon known as emergence delirium. Others are calm and serene. Everyone responds differently. But you're breathing independently. Your heart is beating on its own. You've been brought back. You're transferred to recovery, the PACU, or post-anesthesia care unit. Nurses are monitoring you. You're still receiving supplemental oxygen, still wired to monitors tracking blood pressure, heart rate, and oxygen saturation. And gradually, over the next hour or two, you fully awaken. The amnesia lifts. You become oriented. You remember your name, where you are, what happened. But here's something that rarely gets discussed. What you just went through was profound. Your consciousness was extinguished. Your body was paralyzed. Your most fundamental life functions, breathing, circulation, were commandeered by machines and medications. You were cut open. Your organs were handled. And then you were brought back. You traveled to a place very near death and returned, and for most people, there's no memory of it whatsoever, just a blink. One moment you're counting backward, the next you're coming to in recovery. But that void, that gap in your conscious experience, some people find it deeply unsettling. Where were you? What becomes of consciousness when it's switched off? Does it go somewhere, or does it simply stop existing? These are philosophical questions as much as medical ones, and nobody can fully resolve them. The brain scans can be interpreted, neural activity can be measured, but what happens to you, to your subjective experience, to the essence that makes you aware you exist? That remains a mystery. Some patients report near-death experiences, particularly those who've encountered complications, cardiac arrest under anesthesia, clinical death. They describe seeing things, encountering loved ones who have passed, feeling an overwhelming tranquility, traveling through tunnels of light. Skeptics attribute it to cerebral hypoxia, oxygen deprivation triggering hallucinations as the brain shuts down. Believers see it as evidence of something beyond the physical. Both viewpoints coexist within the walls of every hospital. I recall hearing about a patient whose heart stopped during what was supposed to be a straightforward procedure. The team performed resuscitation efforts for nearly 7 minutes, chest compressions, epinephrine, defibrillation. They brought him back. And when he regained consciousness, he told the doctors he had been somewhere else, somewhere peaceful. He said his late grandmother was there. She smiled at him, told him he still had things left to accomplish, and then he felt himself being drawn back. Was that real? Was it his fading brain assembling comforting imagery from stored memories? Nobody can say with certainty. but he believed it was real, and it transformed him. He returned as a different person, less fearful, more convinced of something he couldn't quite articulate. The dangers of anesthesia are genuine. Death under anesthesia is rare but possible, roughly 1 in every 200,000 to 300,000 cases. The odds increase if you have significant health conditions, cardiac disease, pulmonary disease, advanced age. But for healthy individuals undergoing routine surgery, the risk is remarkably small. You're statistically more likely to die driving to the hospital than from the anesthesia itself. But complications that fall short of death are more frequent. Allergic reactions, respiratory difficulties, cardiovascular instability. Awareness, postoperative nausea and vomiting, a sore throat from intubation, confusion and disorientation, particularly in elderly patients. These things occur. They're managed. The team is equipped for them. But they're part of the reality of anesthesia. There's a weight that accompanies this work, a weight that never lifts and never becomes easier. Every case matters. Every patient matters. The anesthesiologist holds your life in their hands for those hours you're under. An error can mean death. Inadequate monitoring can lead to a catastrophic outcome. People ask whether that level of responsibility ever becomes frightening, whether doubt ever surfaces. And the candid answer is yes. Not in a way that breeds incompetence, but in a way that fuels vigilance. The day that healthy apprehension vanishes is the day someone should walk away from the operating room. Because that fear, a deep, abiding respect for the gravity of what's being done, is what keeps patients safe. So when you go under anesthesia, understand this. You're being looked after by someone who grasps the enormity of what they're doing. Someone who trained for years to handle every conceivable complication. Someone who will watch over you with total focus for the entire duration of the procedure. You're not just another case number. You're a person, a life, someone's family member, someone's friend. And guiding you safely through surgery and back to consciousness, that's not merely a profession. For the people in that room, it's a vocation. The enigma of consciousness, the power to erase it and restore it. The responsibility of holding life and death in the balance. That is what happens when you go under anesthesia. And my hope is that now, armed with the truth, you can approach surgery with less dread. Not because there's no risk, there is, but because you understand what's taking place. Because you know someone is watching over you. Because you know they've done this thousands of times before, and they will bring you back, just as they always do. If you found this explanation worthwhile, if it helped you grasp what truly happens in that operating room, leave a comment. Tell me what frightened you most about anesthesia. Tell me what you wish you'd known before your surgery. And if you're facing a procedure soon, know that it's perfectly acceptable to ask questions. To share your fears with your anesthesiologist. They want you to feel as secure as possible, because your trust in them, that's something they never take lightly. I'm Dr. Dan Carter. Take care of yourselves. I'll see you in the next one.